Welcome to the Bipartisan Policy Center's event to discuss our new national survey, Assessing Consumer Telehealth Experiences. I'm Marilyn Serafini, and I direct the Health Project here at BPC. The COVID-19 pandemic had a dramatic impact on the growth of telehealth and also on changes to telehealth policy. New telehealth flexibilities have allowed millions of Americans to access healthcare from home and even to receive services over the phone, for example. But most of these new policies are temporary, and policymakers and experts are beginning to gather the evidence they need about the usefulness and cost effectiveness of virtual care to make more permanent decisions. With the support of the Helmsley Charitable Trust, BPC contracted with Social Sciences Research Solutions, SSRS, to examine consumer experiences during the pandemic. The survey focused on what barriers consumers faced, what types of health issues they used telehealth for during the past year, and their experiences with telehealth when they had a visit. The survey was conducted over the phone from June to July and included approximately 1,700 people. We fielded the survey over the phone instead of online so that we could reach those people who would be most likely to experience telehealth barriers. For example, people in rural areas who do not have broadband, or people who don't have great digital skills, and those who can't afford a computer, smartphone, or internet access. We believe this survey shows some important findings about the barriers to telehealth, and also we know that it means more study is needed. During the time of the pandemic, the survey addressed how telehealth kept some people out of the ER and addressed the primary reason for the telehealth visit for some people in the first place. The survey also addresses which kinds of services people found to be most useful. Again, this data is still a reflection of telehealth use during the height of the pandemic and not necessarily a reflection of the new normal. We asked respondents to look back at their telehealth visits over the past 12 months, which overlaps with the time before the COVID vaccine was widely available. And some people, as we know, have gone back to in-person care or a mix of in-person and telehealth. Today, we're going to hear first from Jasmine Sutton. She's an associate director at SSRS, which conducted the survey. Jasmine is going to give us the key takeaways from the survey, and then we'll turn to an expert panel to discuss what we can learn from the survey as policymakers move forward with important decisions, and also what more we need to know before we can make those important decisions. If you have questions for Jasmine about the survey, we can take a couple of questions after her presentation and before we get to the panel. If you do have questions, please go ahead and send them through Facebook or YouTube using the hashtag BPC Live. With that, I'm going to turn it over to Jasmine.
Thanks, Marilyn. As Marilyn mentioned, my name is Jasmine Sutton, and I'm an Associate Research Director at SSRS, a nonpartisan survey research firm. Today, I'll be presenting results from a survey we did on behalf of the Bipartisan Policy Center on telehealth use among US adults. As Marilyn mentioned, the COVID-19 pandemic has accelerated the use of telemedicine services across the country with stay-at-home orders, discouraging people from seeking care in person. This survey sought to better understand the use of telehealth services, including what demographics are more likely to use them, what groups are reporting the highest levels of satisfaction with their telehealth visits, obstacles to using telehealth, and how likely they are to use these services in the future. So this survey was conducted via phone on the SSRS Omnibus from June 28th through July 18th. The SSRS Omnibus is a dual frame random digit dial sample of landline and cell phone numbers reaching adults age 18 or over. The survey itself, as I mentioned, focused on barriers faced by consumers, the types of visits they are most likely to have, and the perceptions of quality and effectiveness of those visits. In total, just under 1,800 adults were interviewed, including an oversample of older adults, those 65 or older, rural residents, as well as Hispanic and Black adults. The survey was conducted in English and in Spanish with about 35 Spanish interviews per week. And the survey data was weighted to provide nationally representative estimates of the US adult population age 18 or older. So first, some key findings before we dig deeper into these results. So from a larger perspective, overall, telehealth visits are much more common among those 65 or older. In fact, they were about twice as likely to have a telehealth visit compared to those who were under 30. Overall, about 1/3 of US adults have had a telehealth visit in the past year for themselves or a dependent, and 44% of Medicare beneficiaries have had a visit in the past year, so a big difference there. About 8 in 10 adults say their primary issue was resolved within their telehealth visit. Most telehealth visits are for pretty preventative routine care things like a preventative service, annual physical illness, something for a chronic illness, or prescription refill. We're also seeing similar levels of issues being resolved both in audio and visual, and video appointments. We're also seeing more technological barriers being put forward by rural residents and those who are older adults. Overall, 45% of adults in the country reported some type of technological issue as an obstacle to their access of telehealth. However, those issues were much larger among those who were older and those who lived in rural areas. Older adults were also more likely to have an audio-only visit versus a video visit. As I mentioned, older adults were more likely to have some technological obstacles in getting care, but they're also more likely to use telehealth services in general. So we're seeing that they're opting more for audio visits. Next, about 1 in 7 people who had a telehealth visit would have sought care in an emergency department or an urgent care center if telehealth was not available to them. Another 2 in 10 say they would have delayed care or not sought care at all if telehealth was unavailable. And finally, we're seeing very high rates of satisfaction with the quality of care received in telehealth visits. More than 9 in 10 say they were satisfied with the quality of care they received. Now looking more in depth at telehealth use. First, as I mentioned, among total adults, a little less than 1/3 say they've had a telehealth visit in the past year for themselves or a dependent, and that number is much higher among those who are over 65. It goes down from there among the age groups, with the lowest amount of telehealth use happening among those under 30 at 23%. We're seeing similar rates of telehealth use between rural and non-rural residents, where there is also a big difference between race and ethnic groups. So those who are Black and white are more likely to have had a telehealth visit in the past year at 36% and 32%, respectively, but much lower rates among their Hispanic counterparts at 24%. So as I mentioned, older adults are more likely to have had an audio-only visit rather than video compared to younger adults. So about 47% of adults over age 65 had an audio-only visit in the past year, compared to 44% who had a video visit. And those ways are kind of switched for those under 65, where most under 65 had a video visit. So the most common purpose for a telehealth visit are three types of visit ranked at the top: annual physical, routine visit for a chronic illness such as diabetes, and then prescription refill only. Those three kind of take the top spot. Below that are visits for things like illness and injury, mental health, or substance use, consult for surgical procedure, physical therapy. Those types of visits aren't as common in the telehealth landscape. We are seeing some slight differences in the types of visits rural and non-rural residents tend to have. Rural residents were more likely to use telehealth for a consult for a surgical procedure or operation compared to their non-rural counterparts. This may be that rural residents may not have easy access to these more specialty type services within their community, so they're using telehealth to get access to these things that non-rural residents may have easier access to in person. And I also wanted to note that the stars on the slides indicate that those differences are statistically significant. Next, we'll go to satisfaction with the quality of care received. One issue with satisfaction with care is having your issue resolved within the appointment. The vast majority of respondents say their issue was resolved in their telehealth visit. That's at 80%. Only 4% were directed to follow up in an emergency department, and 13% were directed to follow up in person with their provider. As I mentioned, the most common types of visits are for pretty routine care, like prescription refill, annual physical, et cetera. So we're seeing that there are higher rates of issue resolvement within these types of appointments. In fact, 96% of those who had a prescription refill had their issue resolved within the appointment, and that's significantly higher than for other types of appointments. Now to satisfaction with the quality of care. Overall, vast majority are satisfied with the quality of care they received in their telehealth visit at 94% among all telehealth users. And that's even a slight bit higher among Medicare at 95% of beneficiaries being at least somewhat satisfied with the quality of care they received. Now, as you would expect, issue resolvement is associated with the satisfaction with the quality of care. So those who had their issue resolved were more likely to say the quality of care was that they were satisfied with the quality of care at 96% compared to 84% among those who did not have their issue resolved. Now that 84% is still relatively large considering telehealth use. And we're also seeing similar levels of issues being resolved and satisfaction with care in both audio and video appointments. So we're not really seeing any differences in the levels of quality that respondents tend to be receiving in other telehealth visits. Now, 1 in 7 telehealth users would have sought care from an emergency department or urgent care if telehealth were unavailable. When we asked respondents where they would have gone if telehealth were unavailable, about 14% said they would have gone to an emergency department or urgent care. About 2/3 said they would have sought care with their provider in person, and about 20% said they would have delayed seeking care or not sought care altogether. And digging deeper into that 14% who say they would have gone to the urgent care or emergency department, out of all telehealth users, 8% had their primary issue resolved within their appointment, but they said they would have gone to an emergency department if telehealth was not available to them. Now let's go dig deeper into some of the obstacles faced in accessing telehealth use. First, among all adults, nearly half reported some kind of technology-related barrier in accessing telehealth care. As expected in most surveys, we find that cost and insurance coverage are common obstacles for people accessing any type of healthcare. But in the telehealth space, these technological barriers become of greater importance. So about a quarter are saying that their ability to use the internet or digital technology is a barrier. Another quarter are saying that access to high-speed internet, and a similar amount also say that their access to a computer or device with video capability is also a barrier for them. And about 22% say their own visual or hearing impairment is a barrier. We are also seeing differences in the obstacles reported by Black and Hispanic adults compared to those who are white. So Black and Hispanic adults were more likely to name cost and insurance coverage as obstacles to getting telehealth care. And Hispanic adults were also more likely to say that access to a private location for an appointment and finding a provider who spoke their language to be obstacles for them in accessing telehealth care. Among rural adults, we're seeing that there are more technological barriers compared to their non-rural counterparts. So rural residents were more likely to say that access to high-speed internet and access to a computer or device with video capability was more of an obstacle for them than non-rural residents. Almost 1/3 of rural residents said that these are obstacles for them compared to only about 1/4 of non-rural residents. And we're seeing a similar trend among those who are older, over 65. So older adults, almost half said that access to a computer or device with video capability was an obstacle for them, compared to just 20% of those under 65. Those over 65 were also more likely to say that visual or hearing impairment was an obstacle for them in accessing telehealth care. As I mentioned earlier, these older adults are also more likely to have used telehealth in the past year and use audio-only visits. These obstacles that we're seeing on accessing the internet and accessing video capability may point to some of that discrepancy in their use over time. So even with all these obstacles, respondents still tend to like telehealth overall. And looking towards the future of telehealth, almost 8 in 10 said they are likely to use telehealth in the future for some type of visit with a healthcare provider. That's 71% saying they're at least somewhat likely to use telehealth for a prescription refill in the future. And following below that, just under half say they're likely to use telehealth in the future for a routine visit for chronic illness. And if you look at this data within different race and ethnic groups, we're seeing that patterns of use for a routine visit are actually higher among those who are Black compared to white adults. So there are some differences in what types of visits respondents might use based on some different demographic background characteristics. Thank you so much. That's what I have for you today, and I'm happy to take questions.
Jasmine, we do have a question for you from Kate, who's watching on YouTube. Her question is about mental health and what our findings were regarding mental health, and whether through these findings we can measure the use of mental health services against the electronic availability of mental health services. I'm not sure whether we can do that, but regardless, it would be worth talking about the results as far as use of mental health services.
Yeah, so I can touch on the use of mental health services. So about 9% of telehealth users used it for mental health in our survey. I can't point to availability. It's not something we asked about or really dug into. It's kind of beyond the scope of this. But looking into that 9% of that use of mental health service, it really, if you look at the data a little differently and think about those top 3 conditions that I talked about, or top 3 issues, are all within those kind of established outpatient care of getting a prescription refilled, your annual physical, et cetera. So if you look at it that way, mental health kind of comes in second as the type of care that respondents tended to go for in telehealth visits.
And I will also note that in broad surveys, that mental health and substance use care is coming up very high as a high use item for virtual care during the pandemic. Okay, thank you so much, Jasmine. And I have a feeling that some of the folks in our next panel may be able to add more clarity to that question. So thank you, Jasmine, and we'll move on here. So if there is a silver lining to the pandemic, it may be that it opened the doors very wide to telehealth. People are clearly now more comfortable using telehealth for their healthcare needs, especially older adults who have had the greater ability to have appointments with their providers by telephone. And telehealth can serve as an important tool to enhance access to primary care services and to potentially keep some people out of the ER. So let me introduce our panelists. And again, if you have any questions, you can send them at any time to us through Facebook or YouTube using the hashtag BPCLive. Our first panelist is Dorothy Simon. Dorothy is responsible for the development and oversight of AARP's public policies that address major issues facing older Americans. Walter Panzier is the trustee of the Helmsley Charitable Trust. As a former paramedic, firefighter, and police officer, Walter has personally experienced the significant disparities in quality health care available close to home from everything from a cardiac event to a mental health crisis. And of course, Helmsley is doing a lot of work in this area and in rural. Kate Goodrich, Dr. Kate Goodrich is Senior Vice President for Clinical Analytics and Trends within the Clinical and Pharmacy Solutions part of Humana, Inc. There, she leads the clinical business analytics necessary to deliver better health outcomes at lower costs for Humana members. Before that, Kate held key positions at the Centers for Medicare and Medicaid Services. And our fourth panelist is Ann Mon Johnson. Ann is CEO of the American Telemedicine Association. The association focuses on advancing the adoption of telehealth and on federal and state policy initiatives that would help ensure permanent access to telehealth services. Some of the members are healthcare delivery systems, academic institutions, technology solution providers and payers, and partner organizations and alliances. So, Walter, let's start with you. Until the pandemic, telehealth was long considered a rural issue. So, you've been studying the barriers to using telehealth for quite some time. You also know about the upsides, what it can contribute. What do you see as the barriers to telehealth in rural areas, some of which also exist in non rural areas? And how did these barriers play out during the pandemic? Did the new federal policies help?
Well, first of all, thank you for having me on this panel and having me here to discuss this. To be blunt with your question, the pandemic really supersized everything where telehealth was heading. Prior to the pandemic, access has always been an issue, especially as the survey also pointed out in the older Americans and the senior citizens, having a device, having something simple where they can access telemedicine services. Not just the device is also a problem in rural America, but even the broadband access. So many Americans, once you get outside the cities, have very limited or very slow access. So that's why I really think when we go back to the survey points that we saw presented so well and eloquently, that a lot of the older Americans are opting for phone telemedicine because they don't have access to that. That's not right. I come from a background where whether I was a paramedic or working in law enforcement in rural areas, a picture's worth 1,000 words. Everybody seems really satisfied with the telemedicine they're receiving. But if they had a picture, it's worth that much better. And I could see the rural residents being even more satisfied and seeing an increased uptake with these telemedicine services. But yeah.
Right, you raise a really good point, Walter, and that is that during the pandemic, we did open the door to greater access to telephone services. On one hand, that gives people who don't have access to some kind of care. On the other hand, everyone's not getting the same care. So we have audio services, we have video services, and for people who are in rural areas right now, if they don't have broadband, they might have been using some additional audio services. But I think what I hear you saying is that really what you think we ought to be aiming to generally is video services, get the broadband out there.
Absolutely. That is exactly what I'm saying is we need to get the broadband out there. This goes back to an equity issue. I've always said your zip code should not determine your outcomes and shouldn't determine your access to quality medical care. But we see that. We see that even with the being played out in telemedicine, where people in rural areas might not have that access and be forced to be using telephone, which is an adequate, good service. But once again, it's an equity issue getting equality. So it is, I've always said it doesn't matter if you live on a farm in the middle of North Dakota or in the heart of New York City or New Jersey, your access to care should be equal. And telemedicine should be a leveler of all this access to it.
Mm-hmm. So, Dorothy, let me pull you in here because you represent America's seniors. And, the seniors are facing some of the same challenges, whether they're in rural areas or not in rural areas. But, for some of the same reasons, many of them don't have the digital literacy or don't have the equipment. Survey found that seniors had high rates of telehealth use over the past year, which could be because they used more services. I'd like to get your opinion on that. But also, they face significant technology-related obstacles. 45% of adults reported some type of technical obstacle to accessing telehealth, including digital literacy, access to high-speed internet, and access to appropriate devices. What can we do from a policy perspective to ensure that seniors have access to the care they need virtually, but make sure it's an access point they can navigate? And if you could address some of the issues that Walter raised about audio versus video and how we can make that happen? What have we learned during the pandemic?
Well, our polling, as well as the polling that you all shared today, there's a lot of interest in our membership, older people 50 and above. They want to engage with telehealth. A lot of growing interest in it because they see the promise of it. It can really make things more convenient. You can have really benefits to family caregivers. They see the promise of this convenience. Having said that, we are faced with obstacles, and AERP has been working very hard to push the need and the importance of access to broadband. But I want to unpack that a little bit. Some places don't have broadband at all. Some places have broadband, but it's not affordable. So you have to both get the broadband access and make sure that the community there has a reasonable chance of getting it, and there's real affordability. So it's both of those things. And then you move the notion of, well, how do they access computers, and do they have the capacity to do that? A lot of older people are tech savvy. I want to just make sure I put that out there. There's lots of folks who are using this and really benefiting from it, but we still have a ways to go. There are more people across the ages who need help with digital training, and I think we need to do more to fund that, meet people where they are. If this is truly health access, then we need to meet older people where they are, and all people. There are a lot of young kids required to do this for homework and all of that. Do they have the devices they need? And we need to invest in broadband in this country. We need to invest in tech support so that all populations, and particularly older populations who are trying to reach this, get healthcare. Because I do think it's really useful to have audio, because sometimes that's the only way you can get to the service or get to the clinician you need. But it's not to say audio is the answer all the time, and we don't want to create a two-tiered system where only some communities only have audio. We want to have an equitable system where people can access things, but we need to meet the communities where they are. And that support ranges from both access to broadband, affordability of broadband, and then that training and tech support that's really important to getting people up to speed to doing that. And that can happen in urban areas as well as rural areas. I know the rural areas are really stand out as not having access to broadband, but we have some other places where you'll see people where there's broadband there, but there's not enough intervention about affordability and the access to the computer technology and the training that's needed to access it as well. So older people in these different settings may need different supports, and it comes back to meeting people where they are to effectively access the services.
Thank you, Kate. Health plans and also health systems have been pretty creative during the pandemic in addressing, getting around some of these barriers. We've heard stories about the delivery of tablets or phones to patients' doors. How has Humana addressed barriers to using telehealth during the pandemic? And what lessons have you learned about telehealth, visual, audio, whatever form, that you think may be able to be carried forward or should be carried forward?
I would say I think about it in two ways that are probably pretty obvious. One is the impact on our members and how we can help them access telehealth when that's a desired way to access care or the necessary way to access care. And then also, very importantly, the impact on clinicians in their practice who are working hard to try to stand up telehealth services so they can reach their patients, particularly those who did not already have those in place. So on the member side, we have a very large Medicare Advantage population at Humana, and we also have a commercial population. And we certainly, like everybody else, saw very significant increases in telehealth usage. Interestingly, while we did, of course, as was mentioned by Jasmine in her report out, we saw a huge increase in mental health services being accessed, but as a proportion of telehealth services that were accessed compared to prior to the pandemic, it was almost entirely mental health services that our members used via telehealth, albeit a relatively low amount. during the pandemic, everything went up, right? And so proportionally, our members were accessing telehealth for chronic care. So one of the things that we did was really reoriented our care management work inside Humana to really try to identify our members who were most at risk for both hospitalization, for not being able to get their refills. And we have, pretty good data to be able to understand, who those members are. But we also collect data on social determinants of health on our members. And so we made a particular effort to reach out to members who have, greater social needs, and in particular, if they also had greater physical needs, and really work directly with them to get them access to hopefully their own physician or clinician, but where that wasn't possible, get them access to a physician or clinician. And actually what we saw when we looked back at our data during especially the early months of the pandemic, so from March to about June or July, is we saw that while we have services available for our members, like MD Live and other vendors like that, the vast majority of our members use telehealth with their primary care physician and not with one of our vended solutions. So people really wanted, with this new technology, to many of our members, I think felt more comfortable with it if it was working with their own primary care physicians. And then on the provider side, we learned a lot there. We were really interested in understanding in our provider community, our providers who are on the path to value and providers who are not on the path to value, is how telehealth played out within their practices with our members. And what we found, very interestingly, or perhaps not surprisingly, is our members who are attributed to practices that take on full risk, or at least take on some downside risk, had way higher rates of telehealth usage than members who are attributed to straight fee-for-service practices or
Kate, take a half a step back and just explain what the difference is there.
So we have something we call the path to value, and it falls into 4 basic categories. One is fee-for-service, so not, perhaps providers are held accountable for quality measures, but they're not taking on any kind of upsides or shared savings. Right? When we say upside and downside risk, what I'm really talking about there are shared savings models where our provider practices can, share in the savings if they spend less than a target over a year, for example, or they perhaps lose money if they spend more than that particular target. And then you have, so there's fee for service, our providers who are just sort of dipping their toe in the water to be on that path to taking on more risk down the road, who are only an upside share savings. And then we have our practices who take on some downside risk, but they're not at full risk, like global capitation, all the way up to full risk practices.
So meaning downside risk, they get dinged if they don't meet targets.
That they don't meet spending targets, and also that it's the other factor, of course, is their performance on quality metrics, right? That's very important. And so our practices that at least take on some downside risk, but particularly our practices that are at full risk, had much quicker and much greater telehealth usage that was then sustained than our providers who were straight fee for service or only upside risk, right? So that was a very interesting finding. And we also did some qualitative work to try to dig into that a little more. And I think, it may not surprise people watching that if you take on downside risk, if you definitely have money on the table that is at risk and you are incentivized to be efficient with your dollars and to meet quality targets and outcome targets as well, most of these providers have oriented their practices towards improving the patient experience and improving health outcomes. And it's just their orientation. And so many of them either already had some telehealth capabilities in place, or because of the incentives that they are aligned to in their day-to-day work, they worked very quickly and very hard to stand up a telehealth capability so that they could continue to meet their members' needs and their quality targets. And our providers who were in practices that do not take on risk. Some were certainly able to stand up the telehealth capability. But what we heard was that actually that was frankly a lot harder and happened in a lot slower. They didn't really have the infrastructure inside their practice to be able to readily stand up a telehealth application. Many of them got there, but it was definitely slower going.
Anne, let's turn to you. I have another question for you, but first I'd really like to get you to follow up on what Kate was just talking about. You have these two kinds of healthcare delivery, and the doctors and other clinicians that they're participating in, and the movement has been toward value-based care, or taking on the providers taking on greater risk, getting a lump sum of money or a capitated payment to take care of all the, a certain group of needs of their patients. There is a lot of discussion right now about the path forward for telehealth and virtual care services, and whether it should be limited to this kind of arrangement, or how you make it work in an arrangement that is not like that. That is more the fee-for-service model, where patients can the provider is not responsible for the cost if it's, if they don't meet their targets.
Well, it's a great question, and certainly one that we're working through with our members. I would say that from our perspective, and I think Kate really underscored this in her experience with Humana, that telehealth is health, and it should be viewed as a modality that a clinician can use at their discretion. And that is synchronous, it's asynchronous, it's remote monitoring, it's audio only. And it's really up to us to ensure that we remove many of the continue to ensure that the regulatory barriers that were waived become permanent. And because of that, then people are able to get the care they need where and when they need it. So it's really this notion of meeting people where they are and taking away the encumbrances that providers have had to work through to provide care to patients in the way they think can be best done. And so that's really what we've seen. And I thought the data, of course, was very, very exciting, because it demonstrated, like most other surveys that we've seen, that when given the opportunity, people, meaning patients and providers, used telehealth and they liked it. And I thought what was interesting as well is that if telehealth is not offered, people said they would have used the emergency room, which is very expensive, or they would have avoided care, which is also expensive down the road. So that's, this is something that we've really exposed. And I think it underscores the importance of making sure that the changes that we've seen become permanent.
Okay, so I'm going to address this question to you. We actually have another question from Lester from YouTube. And Lester wants to know what is being done about language and cultural barriers, and how big of an issue is it? How can telehealth address this?
Well, it is a big issue, of course. And I think when Dorothy started laying out the different levers that we can pull in order to use telehealth to address the disparities and inequities that are in place, she spoke to broadband and connectivity, the affordability of the plans, which was second. The third was access to devices. The fourth being literacy. And I love how Lisa Fitzpatrick at Grapevine Health talks about the importance of us making it easy for our patients and providers to use these services. It's not up to a patient to be literate. And then the fifth is this notion of trust or bias. And I think you have to address all five of these in order to really begin to resolve the inequities that we've seen. So when you think about how language or culture has been used in the past, or has been addressed in the past, we have, of course, technology that makes it a lot easier to connect the right person to provide translation services, for example, and have seen a lot of innovation in that regard with many organizations. Likewise, from a culture perspective, the idea of making sure that we design for the user and not for the person who's putting the product together is another important factor as well. So I think that what we're seeing is just the beginning of innovation in many instances, and I think we're going to see tremendous progress. I just hope that we do it in spite of the fact that value-based care is not everywhere, that we're going to keep seeing it happen.
Well, we certainly know that cultural competency is an issue. If a provider doesn't understand the culture of a person, then they're less likely to stick with that provider. And we know that is especially true when it comes to mental health and substance use treatment. That it's very difficult if a person is not connecting with their provider. It's important for their primary care as well. We know that people will just not go to a provider who they believe, some people who they feel that the provider does not understand them.
You see how important it is then to ensure that we address this, because it's not just it's an issue of trust. It's if you don't have trust in your provider, then you're not going to get anywhere. You can have all the devices and the connectivity in the world. And so this extends to communities of color, making sure that they're not feeling judged. It extends to the LGBTQ community as well. So yes, the primary care provider, but any provider, it's really important to ensure that there's that element of trust and they're being genuinely understood.
Great. So let's turn to some of the policy issues. During the pandemic, we have seen Congress and the Trump administration took some steps to make telehealth more easily accessible. People now are able to get telehealth in their homes. They're able to get it through audio. There are just lots of flexibilities that are out there. Now, these flexibilities are not permanent, they are temporary. So I'd like to turn to some of the panelists and ask you what you would like to see, what you saw during the pandemic, and what you think is important to keep as we move forward. And let me turn first to you, Walter.
Sure. Well, what we saw during the pandemic was basically opening of telehealth. The Trump administration totally opened telehealth, so everybody had access in some sort of way, like you said, either audio or video. To me, going forward, that was a great thing just because it really pushed telehealth to the forefront. It wasn't just a rural issue with telehealth. All of a sudden, you saw urban settings, whether it's your poor urban settings or even your suburban people wanting to use telehealth because of convenience and just access on their own time, etc. Going forward, I think it's really important to make sure we don't go backwards in telehealth. When I say we don't go backwards in telehealth, I'm talking about all the providers. All it takes is one real bad actor, one real bad problem, regulations will come back into play. And this goes back to my point that this shouldn't just be looked at a cost lens. To look at this as a cost to save money for the provider or the healthcare system or insurances shouldn't be the only lens we look at this. We need to look at this at a quality lens and really be accountable to each other to making sure that a telehealth visit should be the same, should have the same feel, the same equity, and the same outcomes as an inpatient visit. And to making sure that all institutions are doing this, regardless whether it's mental health or whatever.
Mm-hmm. How do we do this, Walter? Do we need some kind of lots of new players are going to get into this field. Do we need I'm about to ask you something that could be controversial, but do we need some kind of a certification for telehealth players?
I absolutely believe we should have a certification. This is just me believing this, because if there is a certification, we have guidelines. We have certifications and guidelines for quality of care and quality standards all across the field of medicine. Why not for telehealth? There should be some guidelines, because if you have those guidelines, you can hook that back to payment requirements. to making sure they're meeting the quality, meeting the outcomes. And this isn't just the cheapest way of doing it. A doctor in a box somewhere else who opened up a shop on a way to make money. This should all be based on quality outcomes. And that's the only way to do it, in my opinion, is to have something where we have quality education and quality certification upon providers and potentially systems.
So I'd like to, okay, who?
Yeah, this is
Please.
Anne. I just wanted to add that in terms of the policy that needs to be made permanent, we are working very hard on behalf of our members and the community at large to ensure that 1834M, that goes away. This is it's a shackle in essence that encumbered the use of telehealth that was put in place in 1997, 14 years before the iPhone became invented. And so I think it's pretty clear that we are going to go off a cliff, as we refer to it, the telehealth cliff, if this is not put to bed once and for all. I think the whole notion of originating sites and the surge of activity we've seen from the FQHCs and RHCs is evidence that people can really use this care and service. So these are really important policy measures that if we don't push for, it's going to go away.
And Anne, explain to the audience what were the restrictions before, and what are the temporary restrictions we have in place now about where someone can give and receive telehealth?
Well, it's very restricted, and it really didn't make much sense given how you use your phone, right? So you had to have telehealth services. It would be reimbursed if it was in a rural community, and if the individual went to a specific location and their physician was in a specific location. And that is just not meeting people where they are. So that's why we're talking about 1834M needs to go by the wayside.
Okay, Kate, anything from you on this?
Well, what I would say is I love Walter's comments about quality. This is something I've spent some time thinking about, even actually before the pandemic, because of the recognition that, we now have iPhones and that moving to a more digitally enabled world should mean that we have more capabilities for telehealth. And yeah, there needed to be congressional action for a lot of that to happen. But so one thing I spent a lot of my time at CMS thinking about was, what does quality look like for healthcare delivered through this modality? And my view is that you should be measuring essentially the same things. It's not a different type of care, it's a different modality of care. And NCQA, the National Committee on Quality Assurance, to their credit, very quickly, they'd already been working on establishing telehealth codes within many of their quality measures. And when the pandemic began, they accelerated that effort for a number of their other measures that health plans use. So I think that this is something that CMS and other players who develop and use quality measures need to take on. And frankly, I also think that there really needs to be, I'll call it a research agenda. It doesn't necessarily mean an academic research agenda, although I'm sure that should be part of it, to really understand deeply and precisely the impacts of some of these changes and the impacts of quality on different modalities of telemedicine delivery, among many other things, including some of the concerns people have around payment. We need to actually study that to understand if it's in fact true that telehealth increases costs, because I think a lot of us believe that actually the opposite is true. So I think there's sort of a whole research agenda in addition to some of these no-brainer policies that should stay in place. There's just an agenda that needs to be set forward and really be very thoughtful about.
What does that? Yes, Dorothy.
I was just going to jump in and echo that. I think it's really important to, people want to get care in their homes and they want to have other sites where they can access care. But I do think I support what Kate is talking about in terms of a research agenda to learn more. We need to learn more about what the impact on quality is and understand both the impact on quality and price to better understand what a full range of changes would impact individuals and the programs. such as
So
that.
are you advocating then for Congress to really delay making permanent decisions until we get out of the pandemic and see what some of the impact is, where we are, what's the new normal?
Well, I think the issue now, I think, is there, and we participated in the NCQA group that looked at a range of these things and put forth some notions of things that could be permanent, particularly eliminating the site restrictions and those kinds of things. But more broadly, I think we have more to learn.
Okay, so we brought up, several of you have brought up the issue of payment parity, or how much doctors and other clinicians get paid for a telehealth or virtual care visit compared to an in-person visit. This is one of the things we need to study. What do we know about payment? If you pay too little, you're not going to get doctors wanting to do this. If you pay too much, then so what are the ups and downs here? Anne, Anne, do you want to start with that?
Well, sure. And again, just going back to a prior comment about there's the issue of receiving care through telehealth or not receiving care at all. And I think that we have to acknowledge that, because sometimes people just will not have access. Look at mental health services, for example, what a shortage we've had. As it relates to payment, we advocate for fair payment. So we're not in the business of setting prices between private parties. And again, speaking to the experience that Humana showed, that Kate talked about, is that in a value-based environment, you're going to use what makes the most sense and really responds to the issue. And that's really what we think should happen writ large, that providers should have access to this modality of care, and in consultation with their patient, decide how they're going to work with their patient. So that's really what we're advocating for.
Okay, so our survey showed that a number of people reported that the issue that they came in with to a telehealth visit, that primary issue was resolved. How do we reconcile that with potentially what kinds of services people have been using? And what does that mean going forward? Kate?
I think it's very reassuring that people felt like their issues were resolved. Again, this is frankly, I think, where I think there's a lot that probably can be done via telehealth. More than we may necessarily realize, but there are clearly some limitations to that because of the inability to, conduct a physical exam. But there's some solutions for some pieces of that I think I would hope to see sort of more innovation in that space as well, around being able to, understand vital signs. But there may be other ways in which we could have access, or a physician or a clinician could be able to, virtually examine a patient. Certainly procedures can't be done by telehealth, but I think this is also where we need to have a much better understanding of the landscape of what the practice actually has been, and what the innovations have been over the last year, to be able to capably and with high quality care for our members who are accessing providers by telehealth. I don't think we can just assume that it's all of one particular type. So I think that is an area where I believe that we actually have quite a bit to learn around what practices were occurring sort of out in the field, to be able to, because doctors want to deliver high quality care, to be able to meet their patients' needs.
Good, thank you. We have a question from Dina, who's watching on YouTube. Dina would like to know whether training is needed for healthcare professionals to deliver quality medical services through virtual care. Also, is there patient education on how to have a productive call or a video session? Let me turn to perhaps Anne on that one.
Sure. So absolutely. I think that what the ATA first did when it was created in 1993 was establish practice guidelines across different clinical specialties as well as settings. And today we're embarking on what you might call next gen practice guidelines, the notion of hybrid, that telehealth is not appropriate for everybody or every use case, but there are many where it should be used. And so a combination of practice guidelines and really identifying the use cases and spelling out what hybrid looks like is an important focus of the organization. And at the same time, you have groups like the American Board of Telehealth, which is really focused on certification programs in different specialties and different situations as well. And then we have a number of partner organizations that, like the National Organization for Rare Diseases and ALS Foundation. And these are groups that are very front and center, ensuring that their communities know how to use a telehealth visit as well, and partnering with them in many instances. So I think the opportunity and the obligation we have to ensure that this is done correctly is really tantamount.
Walter, you've been on the ground with these issues a long time, and I'm wondering what you have seen from rural areas and what you think would be helpful.
Absolutely. I totally agree with Ann 100%. There is training out there for the professionals. We also have to, in my opinion, make it easy and seamless for the professionals. That goes back to the organization, where they can transition from one telehealth visit to a virtual patient visit via telehealth to a real live patient. And what does that really mean? Well, in the real world, that means having telehealth set up appropriately and simply in their office, not having to go like years ago. The physician would have to go down multiple halls and go to the telehealth consult room, and it would be terribly inefficient on the physician's time. So it doesn't encourage physician uptake. So it's not just training the physician how to use it, what are the outcomes on it. But I truly believe all of us in our own organizations need to do a better job at training the public on what to expect, on what an outcome is, what outcomes should you be expecting, what's a telehealth visit look like, what is the I've personally seen it in rural settings, not just with myself, but with other individuals I personally know in rural settings, where they aren't trained on how to even turn the thing on. So there's a lot of fumbling around, even before, causing late appointments, causing all different sorts of problems that doesn't always make it a successful telehealth visit. So there really has to be some better public education, this goes back to educating your patients, educating the users on how to use this great device. What are the outcomes? What's it feel like before they even get into the room on a televisit? And that should happen in time, I would think.
Dorothy, what about caregivers?
Yeah, thank you for provoking that. I think it's just really important. AARP does a lot of work around supporting caregivers and acknowledging them and trying to get systems to integrate caregivers more effectively. And I think this is a really important point here where, if you want to have a successful telehealth visit, integrating the caregiver can be really an important positive part of that, whether it's a off-site caregiver who can engage because they don't live in the same place. And we have many caregivers who are trying to help and support their family members who live elsewhere, or an on-site caregiver who lives in the home or comes to the home when the patient is having that visit. I think caregivers are a really important resource to tap, and also they need the support of what they can engage with too, because when they become better at understanding how care is delivered, they're more effective caregivers. They have more confidence in supporting that patient and doing their job as well.
Thank you. We have about one more minute, and we do have one more question. Lisa, who's watching on YouTube, would like to know about accessibility of telehealth for people with disabilities and what we have seen there and what we have learned. Anybody?
Well, again, I would just say that we have to start with the user in mind. And so this is something that extends to people living with disabilities. And we have not done a great job as a society in this. And so before you start reimagining how technology can solve a problem, you have to reimagine the problem and really start with the user's point of view. I think by the same token, this notion of making things very easy for people is important. And that's what's encouraging about having companies like Best Buy Health enter the market, because they're coming at it from a retail perspective, which again is very different from how we've approached things from healthcare historically. So I find that exciting and encouraging as well.
Great, thank you. So we have reached our time. I'd like to thank all of our panelists for their insight. I'd like to thank all of our viewers. And I'd also like to thank Helmsley Charitable Trust for their support of our work in this area. We are continuing to do work in this area, so please watch your email from messages from us about what we're finding, and we look forward to the next conversation. Thank you.